Why asthma causes pulsus paradoxus? Well, this is very high yield US concept for step 1, step 2 and step 3, and I will try to make it simple. But before I start breaking it down, I will ask one simple question that what is the difference between physiologic pulses and pulsus paradoxus? Well, you would be better able to answer this question if you know the basic respiratory physiology behind all this. Well, during inspiration, the interthoracic pressure drops. Normally, about mildly, there's mild decrease in interthoracic pressure of about -5 to -10 centimeter of water, and that drop in intrathoracic pressure basically increases venous return to the right heart and right atrium and the right ventricle, which in turn causes the bulging of the interventricular septum into the left ventricle, which in turn reduces the left ventricular cavity size and in turn left ventricular stroke volume, and that in turn decreases the systolic blood pressure on inspiration. But you should remember that normally this drop in systolic blood pressure on inspiration is less than 10 mm, and that is called physiologic pulses, and it's barely noticeable. But in patients with asthma and severe acute asthmatic attacks, status asthmaticus, actually what happens is that there is severe airway obstruction due to bronchoconstriction and mucus plugging and mucosal edema, so they have to generate massive interthoracic pressure in order to overcome that massive negative interthoracic pressure in order to overcome that airway obstruction. So in patients with asthma, a much higher and much greater negative interthoracic pressure causes the massive venous return to the right heart, and that in fact causes the right ventricle to distend, and as a result, but obviously right ventricle cannot expand beyond a certain limit, as pericardium obviously has a limited compliance, and that in turn causes the interventricular septum to bulge into the left ventricle, and that reduces the left ventricular cavity size, left ventricular diastolic volume, and obviously left ventricular stroke volume, which contributes to the drop in systolic blood pressure, as we see in patients with asthma on inspiration. And apart from this, there are other factors that are also at play that you're already familiar, that in patients with asthma, there's a phenomena going on called hyperinflation or air trapping, because in patients with asthma, because of severe airway obstruction, because of bronchoconstriction and mucosal edema and mucus plugging, they are unable to basically empty their lungs fully. So what happens is that their end expiratory volumes progressively enlarge, and as a result, their lungs are operating at much higher lung volumes. So that basically leads to hyperinflation, which you also sometimes see on physical examination as a barrel-shaped chest, or sometimes on X-ray chest as a flattened diaphragm. And what is actually happening, that because of this hyperinflation, their alveoli are over distended. So as a result, their alveolar vessels are stretched and compressed, and that basically results in increased pulmonary vascular resistance, and which in turn increases the right ventricular afterload. Right ventricle has to generate a much higher wall tension in order to pump the blood into the pulmonary vasculature. So when there's increased right ventricular afterload, obviously that adds to the right ventricular distension and further exacerbates ventricular interdependence, the bulging of the interventricular septum into the left ventricle. So as a result, further reducing the left ventricular cavity size, left ventricular diastolic filling, left ventricular stroke volume, and further causing a drop in systolic blood pressure that we see in patients with asthma on inspiration. And apart from this, there is another factor that we see in patients with asthma, that on inspiration obviously causes where causes a massive drop in intrathoracic pressure that adds to the left ventricular transmural pressure. So what is left ventricular transmural pressure? It's actually just a pressure difference inside, outside the heart and inside the heart. It's intrathoracic pressure minus pericardial pressure. So when there is a much higher left ventricular transmural pressure, left ventricular afterload much increases. Left ventricle has to generate much higher wall tension in order to overcome this transmural pressure, in order to eject the blood from the left ventricle into the aorta. So that obviously reduces and contributes to the reduction in left ventricular drop in stroke volume, and further obviously drop in left ventricular stroke volume, and in turn systolic blood pressure and inspiration, as we see in patients with asthma. And apart from this, there is another factor that we see in patients with asthma that contributes to the drop in systolic blood pressure and inspiration, as is also related to drop in intrathoracic pressure. So much negative intrathoracic pressure that we see in patients with asthma causes also the lungs to expand, and also allows the pulmonary vessels to accommodate more blood, and as a result the blood pools in the pulmonary vasculature. So what happens is that that also contributes to the reduction in left ventricular preload, and already when their left ventricle is very left ventricular afterload is decreased, and there is left ventricle has to overcome increased left ventricular transmural pressure to in order to pump the blood, that is already small amount of blood because of ventricular interdependence, and different factors that I already have mentioned. And when the reduced left ventricular preload also contributes to that, that further results in reduced left ventricular systolic blood pressure, and overall all these factors when added up lead to a drop in more than 10 mm of systolic blood pressure on inspiration, as we see in patients with asthma, and this is actually termed as pulsus paradoxus. And what you should remember, that we also see pulsus paradoxus in other conditions as well, as for example in a cardiac tamponade, where the fluid in the pericardial space basically limits the expansion of the cardiac chambers, and obviously that also results in pulsus paradoxus. And apart from this, in constrictive pericarditis, we also see this pulsus paradoxus, and also in tension pneumothorax or massive pulmonary embolism or other conditions where we see this phenomena of pulsus paradoxus.